So tonight's session is on M mode, and what we're going to do, we're going to look at the normal structures. In order for you to pick out stuff that's abnormal, you have to know what's normal. So we're going to go over normal structures. You're going to see what normal structures look like on the M mode, and then we're going to go over a series of pathology. But also bear in mind that if you come across something and you're not sure what's going on, M mode can assist you. So classic things on your M mode is aortic stenosis, the bicuspid aortic valve, aortic regurgitation, mitral stenosis. So all exams going to have this. So again, those of you who are doing exams, you need to know what the classic M mode of these different pathology looks like. Hypertrophic obstructive cardiomyopathy, very distinctive on the M mode. Left atrial myxoma as well. Systolic heart failure, pulmonary hypertension, pulmonary stenosis, and tamponade. So all of these things are very classic on the M mode, and you're going to get it in your test. So when we talk about M mode, it's a unidimensional echo. This is what we had at first. We call it's a time motion mode. Okay, unidimensional is a one-dimensional assessment, and it's commonly referred to as the Heiss-Pick view of the heart, and it probably got its name from some of the early workers would stick the Heiss-Pick in the cadaver, and then do the M mode, see where the Heiss-Pick is, and then in the dissection see what it's related to, and then sort of match up things. We don't have to do that today. With your M mode, we have two axes. We have the horizontal and the vertical axis. The vertical axis is the distance, and your horizontal axis is the time. So your M mode is a very good tool to measure thickness, length, and stuff. If you're going to measure anything, we talk about displacement. So if you want to measure displacement, then the M mode is very good for that. And the difference between displacement and distance is displacement is a vector quantity, whereas distance is a scalar quantity. So when we talk about displacement, it is distance with a direction. That's the only difference. So we use M mode to measure displacement. Again, the vertical axis is your displacement axis, and the horizontal axis is the time axis. Everything we do in echo is gated. That is, it's either systole or diastole. And another important, this appears on all echo exam. M mode it has superior temporal resolution as compared with two-dimensional echo. This simple little question here appears on all echo exams. Okay, so if you have a structure that is moving very, very fast, the M mode would be very suited for assessing that structure. Okay, the superior temporal resolution compared to your M mode echo, so compared to your two-dimensional echo. All right, so when we do our M mode, today we always have our two-dimensional echo guide, and when we do M mode today, we have a little two-dimensional echo on top, so we know exactly where the cursor is passing through and the different structures that the M mode is looking at. In the earlier days when they were doing M mode, they did not have that luxury, because remember, M mode was developed first, so they didn't have any two-dimensional echo. Okay, so they have no guidance. So you put your probe on the patient and you get your squiggly lines and you need to figure out what's going on. We don't have to do that today because our M mode is guided. All right, so again, we're going to look at normal structures. So one of the normal structures we look at is the mid-ventricular level, the M mode at the mid-ventricular level. So on top, you have your two-dimensional echo. And just for orientation again, this little symbol is your probe or transducer. Okay? And then this is the heart, and this is your cursor. So the cursor indicates the different structures that the M mode is looking at. So again, your transducer probe is right here. It is sending out ultrasound beam. The first structures that the ultrasound beam encounters is the chest wall. So it encounters the chest wall. Below the chest wall, then you're going to have your pericardium. Below the pericardium, you have the RV wall. So chest wall, pericardium, RV wall right there. Because see the cursor, your cursor comes this way. So it encounters the chest wall, okay, the pericardium, the RV wall, then it goes through a portion of the RV cavity, then it comes to the ventricular septum, then it crosses the ventricular cavity, and you have the posterior wall right there. Okay, so these are the same structures that you're gonna look. Okay, so these are the same structures that the M mode is showing right here. So the chest wall, and you can see the chest wall is a linear structures. There is no displacement to the chest wall. Okay, below the chest wall, so this thickness here is the chest wall. Below the chest wall, then you have the pericardium. Okay, because that's the structure that the cursor is seeing. So from the pericardium, then you have, just below the pericardium, you have the RV wall. The RV wall, so you can measure RV thickness. And then below that, this is your RV cavity. So with your M mode tissue gonna have this gray appearance, and fluid is gonna look black. And because the RV cavity is filled with blood, it is black, or it's black. Okay, so the next structure, okay, so this is your RV cavity. Below the RV cavity, this is the septum. So this is the septum, and the septum is wavy because it's moving. Okay, in systole, the septum moves down towards the posterior wall. In diastole, it moves away from the posterior wall. Systole, it moves down towards the posterior wall, and in diastole, it moves away. So this is your septum, and you can see the motion of the septum. Below the septum is the LV cavity, because that's what the cursor is looking at, the LV cavity right there. Again, blood is black, so that is why what's inside here is black. Tissues have different shades of gray. Okay, this here is your posterior wall. So it's your posterior wall. In diastole, the posterior wall moves away from the septum. So because the LV cavity fills, so the walls are separated. So the posterior wall goes in one direction, and the septum goes in the opposite direction. In systole, however, they come together. The septum moves downward towards the posterior wall, and the posterior wall moves upwards. So diastole, systole, diastole, systole. So this is what a normal mid-ventricular cavity M mode looks like. Okay. Again, you need to know what's normal before you can determine what is abnormal. So again, the RV wall, the RV cavity, your septum, LV cavity, posterior wall. And the structures that are moving, you will see they're moving. You know, the pericardium and stuff is moving, so you can see it's not stationary like the chest wall. All right, so, and another important thing, the current recommendation is not to do measurements within M mode. You do measurements in two-dimensional with two-dimensional echo. You still need to know how to do your measurements with M mode, but it is no longer accepted. You know, the American Society of Echo recommends that you do your measurements with two-dimensional echo, not M mode. So you can measure the septal thickness, and your septal thickness should be done at the onset of the QRS. That's another exam question, because they want to make sure you know how to do these measurements. So even though it's not recommended for you to do M mode measurements, they're still going to ask you questions related to that. Okay, so again, you always have your ECG someplace, because everything you do in echo is gated. So at the onset of the QRS, you measure the thickness of the septum. Okay, you also measure the LV cavity size in diastole at the onset of the QRS. So you have to find the QRS at the onset of the QRS, the beginning of the QRS, you come down. So the LV dimension in diastole is from the septum down to the posterior wall. The posterior wall thickness is also measured at the onset of the QRS. Okay, and you measure the thickness of the posterior wall. Again, in all echo exam, these are questions that they ask. You have to know how to measure. So again, I'm going to stress, if you know how to do a regular normal echo, you should do well in any exams. So if you're going to measure the LV dimension in systole, then where the septum dips down the lowest, you just drop a perpendicular down to the posterior wall, and that's your LV dimension in systole. Because in systole, the septum and the posterior wall comes together. That's how the heart pumps. So we move from the mid LV cavity to the mitral M mode at the mitral level. So if you look at your cursor, the cursor is coming like this. Okay, your transducer is right there. The transducer, remember, the transducer emits ultrasound. The ultrasound is going to move through the structures that the cursor passes through. That is the chest wall, the pericardium, the RV wall, a little portion of the RV, a little portion of the septum, a little portion of the LV cavity, then the mitral valve. It's going to encounter the mitral valve. The anterior leaflet of the mitral valve first, and then the posterior leaflet. Okay, so these are the structures that your M mode is going to display. Okay, just, you know, the same structures that the cursor passes through. So again, this is your chest wall. The chest wall is not moving, so it's a straight, essentially a straight line. Below the chest wall, you're going to have the pericardium. Okay, below the pericardium, then you have the RV wall. So if you want to measure RV wall thickness, you can measure it. And if you're going to do any measurement, you should zoom it. When you zoom structures, and for measurement, you decrease the error involved. All right, so the RV wall is right there. Below the RV wall is the RV cavity. Again, blood and fluid have a dark image to it, so it's black. Okay, below the RV cavity, you have the septum. And again, you see the septum is wavy in systole, it moves down, in diastole, it moves up. Okay. Below the septum, you get into the LV cavity. So this is the LV cavity with the mitral valve right there. Okay. And if you look at the cursor, it actually cuts across a portion of the left atrium. So down here is actually the left atrium. Okay. So this up here, because the first structure after it passes through the LV cavity, the first portion of the mitral valve is the anterior mitral leaflet, and then lower down is the posterior. So this is the anterior mitral leaflet, the posterior leaflet to be down here. Again, everything we do in echo is gated. Okay, so your ECG is on top. If you can see the ECG, this would be diastole from the end of the T wave to the QRS. The mitral valve opens in diastole, closes in systole, opens in diastole, closes in systole. Again, so this is the anterior mitral leaflet, posterior leaflet there. And this is how the mitral valve opens. Okay, it closes in systole. All right. The different structures, they will put labels on them, and you need to know what they are. So this is also testable, very testable. Okay, so you have different points on especially the anterior leaflet. And again, this is the anterior leaflet on top. In diastole it open, systole close. Okay, posterior leaflet is down there. Okay, so these are the different points. This is the D point, and if you look closely, the D point is end systole, because remember what we said, the mitral valve opens in diastole, so the D point is end systole, it's going into diastole. Your E point is the early opening of the mitral valve. Remember, the mitral valve opens in diastole, so your E point is the early opening. Your F point is your mid-diastolic closure, and your A point is your atrial systole, or the atrial contraction. When the atrium contracts, you get the A point. And your C point is closure of the mitral valve. Okay, so you can just figure out what's going on, because again, the mitral valve opens in diastole, closes in systole. Or if it opens in diastole, then this is end systole going into diastole. Your E point, this is early opening. This is when the mitral valve opens very early. And then when the mitral valve opens, because of the pressure difference, you get what we call a mid-diastolic closure. Okay? And then at the end of diastole, as you remember, the atrium contracts and you get your so-called atrial systole. And then at the end of diastole, then you at the end of diastole, then you have closure of the mitral valve. Okay, so you have to know these points if you're going to do any exams. You have to know the points. Yes. All right. The next normal structure we're going to look at is the M mode across the aortic valve. Okay, so your cursor is right here. Again, this is your transducer or probe, and the cursor crosses these structures. So these are the different structures that you're gonna display on the M mode. The first structure that the ultrasound beam encounters, again, is the chest wall. Okay, below the chest wall, you're gonna have the pericardium again. Okay, you're gonna have a little portion of your RV wall. Then it's gonna come down. You're gonna have a little portion of the RV cavity. Then you're gonna get, this is the aorta, the wall of the aorta. So this is one wall of the aorta. It's gonna cross the aortic valve and then get to the next wall of the aorta, then it's going to go down into the left atrium. So the structures that are displayed here is basically the structures that the cursor is looking at. So the chest wall, again, it's not moving, so it's a straight line. Below the chest wall, you have your pericardium. Below the pericardium, you have the RV wall. Below the RV wall, the RV cavity, again, blood is black, tissues varying shades of gray. And then you move from the RV cavity, you get to this portion of the aortic wall. So the aortic wall, and it's moving. So that's why, it's not a straight line. Inside of the aortic wall, you have the aortic valve. So this is what the aortic valve looks like. The aortic valve opens into a triangular or box-like configuration, and it closes with a single line usually. Okay, so the aortic valve opens in this triangular configuration. The aortic valve opens in systole and it closes in diastole. Important, you need to look at your closure line. This line is supposed to be in the center of this triangular or box-like configuration. So this line is supposed to be in the center. If it's off-center, then it's telling you that there's some pathology to the aortic valve. The structures, the aortic valve is supposed to be thin and not thickened, so you can see it's supposed to open fairly well. You can see that this aortic valve opens fairly well. Okay, so it opens in systole and it closes in diastole. This is the other portion of the aortic wall, and it's supposed to be fairly thin as well. Then you have the left atrial cavity down here. Okay, again, on the horizontal axis you have time, and on the vertical axis you have distance, and these things are scaled so you can measure displacement, you can measure thickness. Okay, all right, I think this is I think each of these is probably 10 millimeters. Okay, so total is 140, so you can measure thickness, and then time is on the horizontal axis. Okay, all right, so again, measuring cardiac dimensions, the LV internal dimension is measured at end diastole, which is at the onset of the QRS. Again, these you're gonna, people who are doing exams, I can't stress it enough. These are testable questions when you're measuring, so you have to know what measurements you're going to do at the onset of the QRS. So measuring the LV internal dimension in diastole. Okay. However, your systolic internal dimension, you're going to look at the maximal excursion of the ventricular septum, and then you just drop a perpendicular down to the posterior wall, and that's your systolic dimension. Septal thickness and posterior wall thickness, again, is measured at the onset of the QRS. Okay. The aortic root is measured at the onset of the QRS as well. So if you're measuring the aortic root at the onset of the QRS. The left atrial dimension is measured at end systole. You want to get the largest distance between the posterior aortic wall and the posterior left atrial wall. So this is what we mean. So you want to measure this. So from the posterior aortic wall to the LA wall. So this is the maximum displacement. Okay. Again, you need to know that measurements should be done in two-dimensional echo, even though you'll still you still need to know how the measurements are done in M mode. And that's a fair question. They can ask you that because in 2019, you should know that measurements should be done with two-dimensional echo. So one of the things that you're going to see is aortic stenosis. So, and if you see the M mode of aortic stenosis, you should be able to pick that out relatively quickly. Again, your transducer is right there. The cursor is crossing through these structures. Of course, you know the structures that you're going to encounter: the chest wall, your pericardium, the RV wall thickness, the RV cavity. This is the aortic wall, the anterior aortic wall, the posterior. You can see the aortic wall is a bit thickened, and then when you come to the aortic valve inside the aortic wall, it is thickened, and it's probably not opening. We'll call the excursion, open excursion. It's not opening fairly wide. And of course, you know the aortic valve opens in systole and closes in diastole. It's not that the M mode does not, you're not going to use the M mode for any objective assessment of aortic stenosis, but if you see it, you should recognize it, and you should now move on to your two-dimensional stuff where you can get quantitative assessment of your aortic stenosis. Okay? Bicuspid aortic valve. So it's another fairly common congenital abnormality that they will bring, and you more than likely will see it in some exams. Okay, so with your bicuspid aortic valve, instead of having 3 leaflets, the aortic valve have only 2 leaflets, and that lends itself to abnormal flow dynamics, and these patients will have aortic stenosis and aortic insufficiency. So this is a classic case. This one, the aortic wall is thickened because, again, you need to look at a lot of normal M modes so that when something is abnormal, it stands out. So this anterior aortic wall is thickened. The posterior wall is also thickened, and the aortic leaflet is not very thickened. You can see it's fairly thin. But the thing that's very striking is the non-centered insertion of your closure line. Remember what we said about the closure line supposed to be in the center of this triangular or triangle configuration. You can see it's off-centered. It's off-centered. It's not in the center. So if you see, and they're gonna make it obvious, and they're gonna ask you the differential diagnosis, and you need to know that bicuspid aortic valve should be high in the list. Severe aortic regurgitation is another classic thing that they will bring. Okay, so again, your two-dimensional echo transducer is right there. The cursor is looking across these things. So, the cursor is across the mitral valve. Again, everything is gated. Your ECG is on top, and then your mitral valve is inside the LV cavity. If you think a little bit about aortic insufficiency, aortic regurgitation, if it's severe, you're going to have torrential amount of blood going back into the LV cavity. It's going to strike the anterior mitral leaflet, and it's going to cause it to flutter. As a matter of fact, it can produce, if you have significant aortic regurgitation, you can get some functional mitral stenosis because that aortic insufficiency jet impinges on the anterior mitral leaflet and prevents it from opening. So, but when you look at it, you get this fluttering. You see this little wavy thing there? This is fluttering. This is fluttering of the anterior mitral leaflet. Okay? So they will probably give you a little history and then give you this, and you need to know that this is, fluttering. This is significant aortic insufficiency, and that's because the aortic insufficiency jet is going backwards. So again, if you have aortic insufficiency, the blood is coming this way. It's going this way. So it's going to strike the mitral valve. Remember, the mitral valve is supposed to open in diastole. So this blood is going to strike it, prevent it from opening, and you're going to get some fluttering. So that's what this represents. Okay? So you should be able to identify that in the exam. Mitral valve prolapse. Okay, so again, when you have mitral valve prolapse is a systolic phenomenon where the anterior or the posterior mitral leaflet bulges into the left atrium in systole. So ECG is on top. Systole is from the onset of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. So diastole mitral valve opens, diastole mitral valve opens, diastole mitral valve opens, your D point, your E point, F point, A point, C point. But this in systole, your mitral valve is actually going downwards. It's going downwards. So this is what prolapse of your mitral valve looks like. Okay, it bulges downward. Remember, it's supposed to be sort of flat, straight line, but it prolapses going downwards. So you have to be able to identify that. So systolic bowing of the anterior mitral leaflet. Mitral stenosis. So you should be able to identify mitral stenosis. With mitral stenosis, again, the mitral, one of the most common causes, rheumatic heart disease. The leaflets is thickened, calcified, and its opening is restricted. So, of course, your cursor is right there. Two-dimensional stuff is on top. Your transducer is right there. Chest wall, pericardium, RV wall, RV cavity, septum. Septum is probably a little bit thickened, but this is the mitral valve inside of the LV cavity. ECG is on the bottom. In diastole mitral valve supposed to open, diastole mitral valve supposed to open, diastole mitral valve supposed to open. This supposed to be your E point, F point supposed to be there, A point supposed to be there, C point right there. One of the things that you get with mitral stenosis, your E to F slope is not going to be steep, it's going to be flat, okay? And that's one of the hallmarks of mitral stenosis. The E to F slope is not steep, it's flat. And if you look at the anterior mitral leaflet, it's thickened. Also the posterior leaflets are thickened. And the leaflets are not opening. There's no opening or no significant opening between the anterior and the posterior mitral leaflet. So this is classic mitral stenosis. So if they put this on the test and they're going to ask you what it is, you need to know the E to F slope is not steep. You have thickening of the anterior leaflet and the posterior leaflet, and there is no separation of the anterior and of the posterior leaflet. Mitral stenosis. Another classic finding an M-mode is your hypertrophic obstructive cardiomyopathy, showing SAM. Again, two-dimensional echo is on top. Transducer is right. Your transducer probe is right there. Cursor is right here, and the structures that the cursor, the M-mode is going to display: the chest wall right there. Below the chest wall, you have the pericardium, then the RV wall, The RV wall is moving, so it's wavy. Okay. Then you see the RV cavity is right there. Blood is black, so RV cavity. Your septum, and this is supposed to stand out. Your septum is thickened. You can see it. Again, on your vertical axis, you have distance. Horizontal axis, you have time. So if you want to measure, and they'll, okay. So this is in centimeters, so you can measure it. So this septum is probably 1, 2, 2 plus cent. Is thick. It's very thick. You can see. So something is going on inside the LV cavity. We can work that out. The posterior wall is also thickened, and you can measure it to see that it's thickened. All right. So our ECG is on the bottom. Okay. We know that the cursor is crossing through the mitral valve. We know that. So in diastole, which is from the end of the T wave to the QRS, okay, so this is opening of the mitral valve in diastole, open of the mitral valve in diastole, and anterior leaflet, posterior leaflet. In systole, something is going on in systole, consistently in systole. So if you look closely, you have systolic anterior motion of the mitral valve. Systolic anterior motion, because in systole, the mitral valve is moving up towards the septum. So this is what you call SAM, systolic anterior motion of the mitral valve. So they're going to give you this in the exam, and you have to be able to identify it. Okay? You need to know that the septum is thickened, the posterior wall is thickened, mitral valve opens in diastole, but in systole, it's moving up towards the septum. It's touching the septum. Okay? This is SAM, systolic anterior motion of the mitral valve. Atrial myxoma. This is another classic one that they're going to bring. So when you have a typical left atrial myxoma, the myxoma is a tumor, benign tumor. The most common location is in the left atrium, and it's attached to the atrial septum via a stalk. And what happens in diastole, when the mitral valve opens, this tumor tries to get out of the left atrium. It's trying to get out. So, and that's what you're going to see down here. So again, cursor crosses through the varying structures. Okay, chest wall, pericardium, RV wall, RV cavity. This is the septum, and then in diastole, the mitral valve open, and then this structure here is the tumor. The tumor is trying to get out. As soon as the mitral valve opens, it tries to get out. So that is what this is. So in diastole, you see this structure. It's the anterior mitral leaflet, and then this tumor. So this is what your left atrial myxoma looks like. Systolic heart failure is also fair game. And again, you're just going to get an M mode looking at the mid LV cavity. The important thing is your E point septal separation. Okay, so again, you need to remember the different structures, the anterior, and again, sometimes your echoes are not going to be textbook classic. You have to figure out what's going on. So this is your anterior mitral leaflet. This is their D point is right there, E point, F point, A point, C point. Your E point to the septum is supposed to be less than 10 millimeters. So your E point, the E separation of the E to the septum should be less than 10 millimeters. If it's more than 10 millimeters, it's telling you that your LV systolic function is reduced. Telling you that your LV systolic function is reduced. Okay? And another thing, they love it in exams, this so-called B bump. So again, two-dimensional echo on top, cursor crosses through these structures. Again, this is the mitral valve, which opens in diastole, closing systole, opens in diastole, closing systole, open. And then your D point, E, F, A, and then this little thing, we never talk about this. This is the B bump. So D, E, F, E, C is right there, and then this little hump. This is the B bump. And when you see this B bump, it's telling you that your LV end diastolic pressure is elevated, and that's usually suggesting that the patient is in heart failure. Okay, so the so-called B bump. Okay, so they're gonna bring it in the exam. I can tell you that they love these type of things. So again, this is your E, F, A, and then this little this little is the B bump. Okay. All right. So what we're gonna do, we're gonna stop here, and